should be done. CSR and CRP are the main inflammatory markers, and serum protein and fluorescence, there the hyperviscosity will be there if the levels are increased. And ANA and AC should be done for sarcoidosis, to rule out sarcoidosis, which causes vasculitis, and it could be the cause for the vein occlusion. And other autoantibodies as indicated, when in doubt. And additional targeted tests are troponemal serology for syphilis and chest X-ray for TB and sarcoidosis, and carotid tubule is clinically indicated. Some cases carotid artery could be blocked, that could be the cause for the decreased vision. And multimodal imaging is the most importantly should be done, like fundus photography to rule out either it is CRVO, BRVO, just to confirm it and to for a baseline photo. And the OCT should be done to detect macular edema, and also there is a paracentral acute middle maculopathy. There is a hyperreflective band indicates capillary ischemia, deeper layers ischemia, and fundus fluorescence angiography and OCT should be done to rule out capillary non-perfusion in leakage areas. And OCT is a non-invasive method to rule out that.
Very rightly, very nice point you mentioned. So what happens in that central acute middle maculopathy, there is a hyperreflectivity of inner retinal layers, which indicates ischemia. So what happens, there is a between the two limiting membranes, internal and external limiting membrane, there is a hyperintensity of a membrane, which is called as MLM, which is a middle limiting membrane. It is now an OCT sign, which is called as middle limiting membrane OCT sign, which indicates ischemia. So ischemia will indicate a little poorer prognosis. So it is a vein plus an artery occlusion. So yes, sir. So it's combined. Sometimes middle limiting membrane, it can be a combined branch or a central vein and artery occlusion. Yeah. So I just remembered with that PML, always look for the PMLM sign, which is reported in Indian Journal of Ophthalmology. That's a middle limiting membrane. To we can know about the prognosis with that sign. Thank you.
And like in older people, the vein occlusion, it is superficial, and obesity, hyperlipidemia, the age-related conditions. The block will be at the level of AV crossings, therefore it will be back pressure will be there and causes superficial hemorrhages, superficial blood vessels to be and cause superficial hemorrhages. And in case of thrombophilia or hypercoagulability states, and in young patients also, mostly the block will be away from the AV crossings. In that cases, there will be gradual rising pressure and vascular endothelial injury, which causes deeper blood vessels to leak and deeper hemorrhages like gallbladder hemorrhage there. And then, based on the color of the hemorrhage, like if it is bright or dark black color is there, it most could be the hypercoagulability conditions like protein C, protein S deficiency as said before, and hyperhomoglobin syndrome.
Yes. And this is anti-streptolysin board, right?
CRVO young person. So what is the commonest cause of CRVO? Like commonest three most common cause of CRVO in young people?
So in young patients, we generally first most common is the hypertension, second is the diabetes, third is the lipid profile, and the fourth is the hyperhomocystinuria. It is in studies it has been reported that hyperhomocystinuria is an independent risk factor for both vein and artery occlusion. Such as in our case, all the investigations were normal except for elevated homocysteine in the blood. If all these investigations come out to be normal, suppose if homocysteine also comes out to be normal, then we come to the second step, sir, to rule out the blood dyscrasias, such as the protein C, protein S, antithrombin 3 deficiency, factor 5 later mutation, and APLA syndrome, and these are anti-streptolysin both items. So then the second step will come to this, And also very importantly, if it is a bilateral vein occlusion, CPC with peripheral smear cell, because we have seen polycythemia as mentioned, leukemias, they can also present with vein occlusion. Leukemias can sometimes have, we have seen one case which has rod spots also with a clearing in the center. So polycythemia, leukemia, even they say macroglobulinemia, I was studying, so the macroglobulinemia, Walden's of macroglobulinemia can be there. But the one important thing is macroglobulinemia is without the macular edema. So one important point to note is that macroglobulinemia does not have macular edema. And other autoimmune conditions such as SLE and inflammatory conditions which Dr. Suvarna will mention in the like TB, Behçet's and Sarah.
That's very interesting thing you have shared, Dr. Nipun. This is the eyes are window of the body. So you can see the rock spot, and once you send the patient for investigation, then something can come out like the leukemia. And I remember that in the late 1990s era when there was the HIV started. So there was an article from Dr. Viswas about ocular science of HIV. So that article in IGO was very widely read and widely cited. So this was first taught by some of the ophthalmologists. When he sent for the investigation, then HIV came out. So this was a very interesting thing which I mentioned in one of the articles. So please carry on.